So, question 1. Is neuropraxia the least or most severe form of nerve damage? So, is neuropraxia the least or most severe form of nerve damage? Question number 2. Damage to the dorsal columns of the spinal cord will result in a loss of pain and temperature. Damage to the dorsal columns of the spinal cord would result in a loss of pain and temperature or touch. So I'll say that again because I read it the first time round. Damage to the dorsal columns of the spinal cord will result in a loss of pain and temperature, or would it be a loss of touch? Question number 3. Is the first sign of cervical spondylitic myelopathy usually motor or sensory? Is the first sign of cervical spondylitic myelopathy usually motor or sensory? Question number 4. An elderly patient doesn't have a blink reflex, which would be cranial nerve 5 on the way in, cranial nerve 7 on the way out. Why wouldn't you manipulate their neck? So an elderly patient doesn't have a blink reflex. Why wouldn't you manipulate their neck? And question number 5. What is a very early sign of peripheral nerve entrapment? A loss of vibration, B, a loss of pain, C, a loss of touch distinction, and D, a loss of temperature. So what is a very early sign of peripheral neuropathy? A loss of vibration, B, loss of temperature, C, a loss of touch distinction, and D, a loss of pain. So that's the end of round 2. Let's look at those answers. So, is neuropraxia the least or most severe form? It is, of course, the least. So in a neuropraxia, all the connective tissue is still intact. So the axon, the minor sheath, the endoneurium, perineurium, epineurium, it's all there, it's all fine. So effectively what you have is functional block. In an axontomesis, which is the next kind of is more severe, the axon is damaged, but the rest of the connective tissue is fine. So the axon needs to regenerate, but the connective tissue is there, which is obviously easier. And a neurotomesis, the whole thing is severed. So you've completely severed that nerve, and that's the most severe, poorest chance of recovery for that. Number 2, damage to the dorsal columns of the spinal cord result in a loss of pain and temperature or touch. And the answer is touch. So the dorsal columns are going to transmit things like proprioception, touch distinction, that conscious proprioception as well, and 2-point discrimination and vibration sense. So that's why we would use something like Romberg's as a test for the dorsal columns, where you have someone stand with their feet together, have them close their eyes, and then look to see what happens to the balance, because we're testing largely proprioception, which is going to be those dorsal columns. Number 3, is the first sign of cervical spondylitic myelopathy usually sensory or motor? It is, of course, motor. So what's going to happen is the patient will normally complain of stiffness in their legs and a change in bladder control. So they're not going to say outright, oh, I've got spasticity in my legs. So as we get encroachment onto the canal, especially with like a progressive cervical spondylitic myelopathy, one of the first things we're going to hit is the corticospinal tract. So it's an upper motor neuron lesion. So you think of upper motor neuron lesion, spasticity in the legs. They're not going to say, hey, I've got spasticity in my legs. They're going to say, my legs feel stiff and they feel weak. I'm having trouble walking upstairs. I'm tripping over things a lot of the time because they've lost that mobility, right? If you've got spasticity, effectively your muscle stretch reflex has become hyperactive. So as you try to lift your knee or try to bend try to lift your hip or try to bend your knee, you're going to get a reflexive resistance to that. As a result, you don't clear the ground very well. And the patient might say something like, I could trip over a matchstick. The descending inhibition or the conscious control of bladder runs either in or alongside those corticospinal tracts. So again, as we start to get stiffness in the legs, we start to lose bladder control, which sounds like a lot of older gentlemen, right, with prostate issues. So it's important to ask questions in someone who's got a stiff and painful neck, or because CSM is so common as you get older, neck degeneration is just part of our life. So it's important to go and look at motor neuron signs in the lower limb. You'll be surprised at just how often you find something. So an elderly patient doesn't have a blink reflex. Why wouldn't you manipulate their neck? We're worried about cerebrovascular disease. So the blink reflex and the gag reflex are often absent in elderly patients with cerebrovascular disease. This is a good one for us to do as chiropractors, who often get the blame for causing strokes. So it doesn't matter whether you're causing a stroke or not. We don't want to get the blame for it when that media storm starts. So if you have a patient who has other risk factors for stroke, and then you find they've also lost the blink and gag reflex, you know that the arteries in the brainstem are probably not as healthy as they should be, or that we wish they would be, and that might be a risk factor or a potential risk for that patient. And what is a very early sign of peripheral nerve entrapment? Vibration. So loss of vibration is one of the earliest signs of peripheral nerve entrapment. Remembering that with peripheral nerve entrapments, it's sensory first, motor second. So nearly always you'll see loss of sensation, and again, it'll be very fine. So you don't want to just use the pinwheel, which is what we all do, because pinwheel is only pain. And it's thinking of those pathways. The pain is a small pathway, right? We want to use soft touch, and something like a NeuroPen is a great option, because NeuroPen has a microfilament with 10 grams of pressure. So as you push, when you hit that 10 grams, it bends. So you can only ever put 10 grams of pressure on there. So don't just use your cotton bud. You want to use something that guarantees it's the same pressure every time. The pinwheel, you want to hold it properly, so it has little grooves on there. Hold it by the grooves. So when you push on, there's only so much pressure you can put on. The harder you push, the wheel's just going to lift up and it's going to pivot in the opposite direction. The only issue with that is the longer tracks, so the long peripheral nerves, do get damaged over time, especially in the leg, because they're going over the hip, knee, ankle, and toes. So they're going a long way, and there's a lot of leverage on them, so they get tractioned and they get stretched. So you're going to see in elderly patients a loss of vibration sense a lot of the time. So when you put that tuning fork on their toe, they'll say, oh no, I can feel that, it's cold. And then when you ask them about the vibration, they'll say, oh no, I can't, no, I don't do that. You want to then go up their leg. So maybe start on the big toe, go to the medial malleolus, then go to the knee, and find out when does that start again. You also want to do that in patients who have diabetes, even if it's well controlled. You'll be surprised at just how often it's not good.